And so thanks very much for the invitation and for having me here this afternoon. I think Sammy's already given a pretty full account of my background and my job at the moment. And I've been asked to talk about benign hereditary chorea. From what I understand, what is traditional in these webinars is, as you found out a lot about me, it gives me an opportunity to find out a little bit about the audience and who's on the call. And so we ask you to fill in this question is to give an indication, just to select one of what describes your professional background most accurately. So I have an idea of the audience. If you fall into the other category, if you could put your profession in the chat function, then that will help for future, for future webinars as well, to make sure that we're being as inclusive as possible. So I'll just give a few moments for everybody to be able to vote.
Yes, already 83% have responded. We will wait for 10 seconds more and then I will show the results. Okay, so here are the results.
Great, so quite a good spread. So mainly neurologists and paediatric neurologists. So that's always quite daunting as an adult neurologist myself, talking about a predominantly paediatric disorder. So that's going to be good, and some trainees as well. So so really great. Okay, right. So if we move on to the talk. Oops, sorry. Problems getting across. There we go. So just to give an overview of what we're going to talk about today, the main thing that I wanted to do is to try and orientate everyone in the context of Chorea as to which area we were going to be talking about. Chorea is obviously a very diverse clinical sign that's seen in a number of different disorders in a number of different settings. So that was the first bit that I was going to focus on. And then having done that, then to look at genetically inherited forms and specific types, and give an overview of suggested pathophysiology, the phenotype, treatment options, and investigations. And then last of all, because this is quite a tricky area, or I think clinically it's quite a tricky area, to show some videos of other sort of quite closely related genetic disorders that clinically can look very similar, and try and pull out some features that may help separate them out. So learning objectives. So I really hope by the end of this webinar that context will be much easier for everyone, as well as a greater familiarity with the clinical features, common genetic mutations, therapies, and differential diagnosis. So just moving on. So the overview of Chorea in terms of the landscape of Chorea, I think certainly when confronted in clinic, so in outpatient clinic or in the inpatient setting, Chorea can obviously occur in isolation, but was often in the context of a much more complex motor phenotype. And I think sometimes it can be quite overwhelming as to where to place that. So throughout this talk, really useful literature that I've found useful, then at least for this talk, I've put in the section at the bottom. And I think none more so than these two papers that I've come across that provide really good algorithms for how to work through a patient or work through potential differential diagnoses and investigations that you'd want to do if you come across a patient either with a pure Chorea or Chorea in the context of another movement disorder. The Martinez-Ramirez paper looks both adults and pediatric, and then the Brandsma paper is very pediatric focused, very clinically driven paper, but both are excellent. So this, what the overview that I've provided is sort of takes from both of those papers and is a very pared down, very brief overview to not make the slide too cluttered. But essentially one of the key questions for Chorea, as with many other movement disorder, is the time set of onset. So are we talking something that's been present for a long period of time, so it's more chronic in nature, or is it more acute with a sort of subacute onset? And I'm going to deal with the subacute element first to put that to one side, because this talk is much more focused on the chronic element. So potential causes on the subacute side include autoimmune, so things like NMDA, anti-NMDA encephalitis, also post-infectious, for example, post-streptococcal infections that then lead to autoimmune phenomenology. Also vascular hypoxia, so brain hypoxic insults. And then obviously drugs and toxins are always potential causes. So in terms of recreational drugs, cocaine is well recognized to cause a subacute chorea, but also from prescribed medication, things like neuroleptics can cause it. Moving on to the chronic side, because that's really where this talk is focused. And then these divide, as with many movement disorders, again, into both primary and secondary forms. So on the secondary side, I mean, the causes then again mirror some in elements the subacute side. So things like perinatal injury, including hypoxic injury. You can see it in the context of neurodegenerative disease, metabolic causes, and again, autoimmune. But this talk is very much focused on the primary causes of chronic chorea, and these tend to be those with underlying genetic etiology. And although I'm sure this audience is aware of a broad spectrum of potential patterns of genetic inheritance, for the most part, these disorders tend to be either autosomal dominant or autosomal recessive, not exclusively, but just in the sort of more simplistic approach, I've broken it down here. So in terms of autosomal dominant inheritance, without a doubt, Huntington's disease is the most common and most widely recognized inherited form of dystonia, of chorea in that category. And then autosomal recessive inherited forms, quite a broad group, but FOXG1, the Friedreich's ataxia, they all have or can have elements of chorea. But just to orientate you for this talk, we're going to be focused here. So very much in the primary forms of chorea, those with autosomal dominant inheritance. I will touch on some other types towards the end of this talk, but that's where we're going to be mainly focused. Okay, so just moving on. So I'm allowed to ask you a number of questions during this talk. And so the first one is to ask you in terms of with the diagnosis of benign hereditary chorea, mutations in which gene, you're only allowed to pick one gene, do you feel is most commonly associated with this diagnosis? So which gene causes benign hereditary chorea, I guess is the question. So 5 options here. And I'll just give you a few moments just to answer that. I hope as well, just as an aside, that during the course of the talk, I'll also be able to show some differences between these different disorders as well.
Okay, a couple of seconds more and then I will show the results. Okay, so here are they. Okay, so the winner then is the NKX2.1 gene, which is the gene that's known to cause or is the causative gene against the diagnosis of benign hereditary chorea. As I said, the other causes, particularly SGCE and ADCY5, so those both show an autosomal dominant inheritance, so we'll touch on those at the end. PDE10A and the GNA01, those are both autosomal recessive inheritance, and again we'll talk about those towards the end of this talk. But the first part of this talk is very much going to focus on those with inherited NKX2.1 mutations. So just moving on to the next slide, I wanted to start with some video. And this is a young girl who I think was about 3.5 at the time, 3.5, 4 at the time of this video. And this was published, so this video is taken by Dan Lumsden at the Evelina, and is part of a publication that a number of us in the UK and Ireland published now back in 2013. So just get this video going. This is just to show the type of chorea. There are other movement disorders on show here, but it was just mainly to focus on the type of chorea, which is predominantly, here in the upper limbs, very distal, these particularly involving the fingers and the hands. So I just wanted to show that video again for you, because I often find it useful, or it annoys me a lot in talks when people move the videos on very quickly. So again, it's the distal upper limb component, particularly involving the fingers and hands, to keep an eye on there. As I said, there are other movement disorders visible, but we'll talk about those in a moment. So moving on to the clinical phenotypes associated with NKX 2.1 mutations. I've broken this down a little bit, but for anyone who has had anything to do with this area or read anything in this field, they will definitely have seen this Venn diagram before. And the reason for that is predating discovery of the NKX 2.1 mutations is that this disorder was often referred to as the brain-lung-thyroid disorder. And that was because patients presented not only with motor or neurological problems, but also often with lung and thyroid problems as well. And so we'll come on to talk a little bit about all of those components. I just wanted to highlight the elements in the bottom left-hand side of your screen, these other associated features. I'm not really going to talk much more about them, but just to highlight them here. There are some individuals with mutations in this gene, usually those with larger deletions that involve the whole gene and extending into other genes, that have additional clinical phenotypes. So often some dysmorphic features, but short stature, webbed neck, joint laxity, those features. There is also a reasonable literature now of malignancy. Most of the literature in this field is case series and case reports. These are not big case control comparisons or anything like that. But the malignancy that has been reported tends to be bronchial, or that involving the urinary tract, so bladder as well. So just to highlight that. So we're going to focus first of all on the neurological components of this, and we're going to talk a little bit about the lung and thyroid afterwards. But before I do that, and I hope I don't bore anyone too much about this, I just wanted to talk a little bit about the pathophysiology, because I think just a little bit of understanding here means that the clinical phenotypes make a lot more sense later on. I think the key here is that the protein product of the NKX 2.1 gene is clearly very, very important early on in development, probably in utero and embryonic development. And most of our understanding here has come from animal models, so mouse models. So there is a caveat that this may not be directly relevant to humans, but is a good indicator. And I think one of the interesting factors is that animals or mouse models that have mutations in both alleles of this gene die at birth, and they have failure of development of the thyroid. They have significant pulmonary defects, as well as significant structural abnormalities in the brain. So it's clearly a key element early on in development. And from the neurological point of view, it seems to be very important in development of the basal ganglia, so particularly the medial ganglionic eminence and the structures that those give rise to, but also involved in interneurons, and particularly migration of interneurons and inhibitory interneurons, so those with GABA and calbindin staining. And without expression of this protein, you get very ectopic development of those regions. Lung and thyroid, the abnormalities are slightly easier to understand, I think, because the protein binds to regulatory elements involved in transcription of a number of proteins that are important in the development of these organs. And I'll discuss these a little bit later on in terms of how these gives rise then to the lung and thyroid phenotypes. But going back to focus on the neurological aspects, I first of all just wanted to talk a little bit about, we're going to talk about motor and the non-motor phenotype, but we're going to start with the motor phenotype because that generally tends to be the reason that people present to clinic. And that leads me on to the next question. I've front-loaded the questions of the talk while everybody's still awake. And again, this, there's not an exact right answer to that. To this question, but as a whole, particularly in retrospect, what's the most common presentation for those patients with NKX 2.1 mutations. Yeah, so there's a variety of potential options, and I can understand why some people may think more than one applies, but if you could try and pick one, and we'll talk through the different phenotypes then with the next slide. So I'll just give you an opportunity to answer that.
Okay, I will leave it open for another 10 seconds and then we'll show the results. Okay, so here are the results.
Okay, so this one, I mean, hypertonia is the sort of the out and out winner, but also, a decent representation for all the other features. And, bearing in mind the the name for this disorder being benign hereditary chorea, chorea is not an unreasonable suggestion in that setting. Right, so moving on, however, the correct answer is hypertonia, and I will explain that a little bit in the next couple of slides. So just to talk about that, so I'm going to talk about the different stages because the motor phenotype does evolve a little bit, or is described to evolve. And I think maybe birth, I'm not being particularly accurate here, but very early on in life, what's often described, and this may be in retrospect when people look back through the notes or people reflect on what's happened before that, once the diagnosis has been made. But limb hypertonia, or hypertonia generally, so a lack of tone, is often the presenting problem here. And so what can be described in notes is of floppy babies, so very lax and lacking normal limb tone. This then sort of gradually evolves into infancy, and as with many motor disorders, often the presentation to clinical services, if it hasn't happened to beforehand, will be described as delayed motor milestones. And in part, that's because of the hypertonia and the lack of finer motor function, but also it's this age when the chorea tends to present. So looking across the literature, all of the literature, and as I said, these are predominantly either single case reports or case series, that the median age of onset for the chorea in this disorder is around 2.5 to 3 years of age. So in some descriptors are of children who've already started to walk, who then start to regress because they have increased difficulty with balance and maintaining coordination, and it's this stage that the vast majority, I think of patients tend to present to clinical services. As children then progress through childhood, there are reports of the chorea worsening, and that's obviously quite a subjective descriptor, but I think generally what is described is that the chorea becomes more generalized, so more body parts are affected, and as a whole the chorea in this disorder is a generalized chorea. It's not specifically focused on certain regions, but I hope what you could see from that first video is that the amplitude of the chorea tends to be a finer, smaller amplitude chorea than you might see, say, for example, with an advanced stage Huntington's disease chorea. So it's slightly different in that respect. I think what is certainly true as these children progress into young people and into adult life is that the chorea stabilizes, and certainly there are people who report that the chorea improves, but I think the key is this is not a degenerative disorder. There's no deterioration and continued progression of the chorea reported into adult life, and certainly as an adult physician seeing these patients in clinic, the symptoms or the motor symptoms tend to be relatively static. But I mean, I think benign hereditary chorea is a terrible name for this disorder, not least I think that the only correct component of that name is the hereditary component. It's neither benign nor purely chorea, and there are certainly other movement sort of phenotypes that are commonly seen, often described as dystonia and myoclonus. There's difficulties with coordination, then described as ataxia, but there are certainly case reports, a number of describing restless leg syndrome, stereotypies, tics, and a number describing drop attacks. So the phenotype can be quite broad, but there should be a choreic element to the motor phenotype. So I wanted to show this in practice again. So this is the same young girl that we saw earlier who had that distal chorea. This is just to show her mobilizing, and particularly to focus on her left side, because she exhibits some dystonia, both in upper and lower limbs, probably bilaterally, I think, but more so on her left side. And the faster, she's just been asked to run up and down here, but the faster she moves, the more that becomes apparent, as is common for most forms of dystonia. Moving on, the next is a young girl that we see in the clinic in Cardiff. She was, I think, about 18 or 19 at the time that this video was done. So what I've tried to do in all the videos is to show the same element of the examination, so you can make like-for-like comparisons. But here, hopefully you can see with her arms outstretched and her eyes are closed and she's counting to distract her, that you can see the same fine finger movement, or these involuntary movements in the upper limbs, particularly distally. But also what you can see with her is that she has jerks, so myoclonic jerks, that involve both the upper limbs and the trunk. So you can see just some quite negative myoclonus there. She also has dystonic posturing, and during the course of this video, particularly her right hand becomes more dystonic in nature, and as you can see there, freezes at the end. She's also got some cervical dystonia. Now, she's someone who's functioned well through school, done well academically, she's studying, she plays a music instrument, so functionally this doesn't have a big impact for her, but she quite clearly has a multifaceted motor disorder, and I would say from the cases that I've seen, this is a very typical phenotype here. So as Sanya mentioned at the start, I'm very interested then on non-motor phenotypes. And going back again in this disorder, there haven't been big case control comparisons, but there have been several studies that have at least commented on this in their clinical description. So the two main areas that have been described are changes to cognition and to some psychiatric symptomatology. So again, the references at the bottom are useful if anyone's interested in this, but I would particularly draw your attention to the first reference. This is Grass et al. in JNP in 2012. This is from the team in Paris, who've put together, without a doubt, the largest case series to date. So they had 28 cases, and it's an excellent paper if people have a chance to read it. But they're the only ones who've done a comprehensive, a formalized, systematic cognitive assessment on a larger cohort of patients with this disorder. And out of the 28 patients that they described, they felt that 20 had some degree of intellectual impairment. Now, 14 of that 20, 14 of the 28 underwent formal cognitive assessment with a psychologist. The other group within the 20 they felt had intellectual impairment was based on school performance, so that they needed additional help at school. But they found of the 14 assessed that around 20% had a below normal IQ, so under 70. So that's, it's quite a low IQ. Another similar 20% then had a borderline IQ. The Parnes et al. Paper as well, they described 5 patients, and 3 of them were reported to have cognitive impairment, but there was no formalized assessment that was described in the paper. And certainly the case series that we published now in 2013, we described 10 cases. We didn't undertake any formal cognitive assessment, and we based our no cognitive impairment on the basis that these children had gone through mainstream school in the UK, so normal school then, and they hadn't needed any additional educational support or anything like that. So from a psychiatric point of view, as is really common when you've got lots of case reports and case series, is there are a lot of different sorts of psychiatric symptoms have been described, but by far and away, the two more commonly described forms are attention deficit hyperactivity disorder, so ADHD, and obsessive compulsive disorder. And even within those two, ADHD is far more commonly described than OCD. I think, there have been a number of cases where some degree of psychosis, either in isolation or in the form of schizophrenia or postpartum psychosis, have been described, and there have been 1 or 2 cases of depression. I think it's difficult because obviously depression is quite common within the population, but I think in terms of looking for a psychiatric phenotype within these cases, then ADHD and OCD are the more common areas. Just moving on, as I said, to the other components of this, and I appreciate that this is very much a neurology-based webinar, and so the patients that we're going to see are going to have presented, or at least in part have a neurological or neurological signs and symptoms. But I think particularly in this disorder, having an awareness of the other systems are involved, and potentially the need for getting the endocrinologist or the respiratory physicians involved as well is pretty important. So this leads back a little bit to the ideas around pathophysiology, and certainly in the lungs, the idea is that there's failure or reduced production of things like surfactant and secreted globulins, which are really key when children are born in terms or pre-birth, but also born as well in the development of the bronchial tree. And so quite commonly, or relatively commonly described is respiratory distress syndrome. So, I'm sure everyone on this webinar takes, very detailed developmental history. But in that, this is one of the key areas to ask about, and particularly because some of these children do end up receiving mechanical ventilation. And obviously that would come out in the history. The other area is recurrent chest infections. I think, this is difficult because lots of children have recurrent chest infections, but I think in the context of a choreiform disorder, that would give you some clues towards this particular condition. The same goes for obstructive airways disease or asthma, again, very common, but in context would be important. And then some patients develop chronic interstitial lung disease. And you can see some of our patients have had high resolution CT chest scans of their thorax, and you can see like these cyst-like air spaces within the lung interstitium, and that's because of, in part because of the failure of development fully of the tissue. Then the thyroid dysfunction is much more straightforward, I think. Essentially, you have failure of thyroglobulin and thyroperoxidase, and so most commonly it's a congenital hypothyroidism, but thyroid agenesis can certainly occur. I think this would clearly become apparent much earlier in life, with a thyroid storm or a thyroid crisis. So, but I think the hypothyroidism often needs some input from the endocrinologist. So the one thing, going back to this Venn diagram, that I get asked not infrequently about this condition is, what are the relative proportions of cases combining multiple organs? How many cases do we see that combine brain, lung and thyroid symptoms? How many just have brain and lung? How many have brain and thyroid? And I'm doing this very much from a neurological perspective. Obviously, if you were an endocrinologist or a chest physician, then these proportions would be different. And if you look across the literature, these numbers are there's quite a diverse spectrum. But Manju Kurian and I wrote a review, I think back in 2015 now, and we looked across the literature and averaged it out. And approximately half of all cases present with at least some signs or symptoms involving all three organ groups. There are series that describe this percentage to be as low as in sort of 35, 36, but on average it's around 50%. The next most common is combination of brain and thyroid, which is about 30%, and then brain and lung around 20%. But these are obviously averages, across case series throughout. So the next moving on is to talk a little bit about investigations. And again, there are no specific guidelines, and this is just how we would work them up in Cardiff. And I think it's a pretty standard workup. We would probably do most of this at first consultation, or at least first and second consultation, with discussion with patient and or their parent if they were younger patients. And in part, because often, the onset of symptoms, even if you're not seeing them for the first time, is in childhood, then the possibility of an underlying genetic etiology obviously goes up quite a bit. And then, so we would therefore often, routinely do some genetic testing, but then the type of genetic testing varies a lot in people's circumstance. So I know there are lots of people from all over the world that sign into this webinar. And so the type of genetic testing that you have available to you depends on your healthcare structure or the financing of that. So just to give some examples. So in the UK, certainly until probably about 3 or 4 years ago, the only way we could test for this gene was using direct sequencing or Sanger sequencing. And there wasn't a laboratory in the UK that was doing it, so we were sending samples to Germany. And as someone who did a lot of Sanger sequencing of this gene for my PhD, this is a difficult gene. It's not an easy gene to sequence at all. But Sanger sequencing can only look for point mutations. And as I've mentioned, this particular disorder can have larger deletions. Certainly if your option or your genetic testing is available to you and you've done the Sanger sequencing and it's been deemed to be normal, but you're convinced of the clinical phenotype, I would certainly suggest going on to look for any copy number variation. I'm going to gloss over the DNA microarrays, but for a lot of people, the genetic testing available is essentially next generation sequencing. And this is certainly what we use now. We use whole exome sequencing, essentially targeted in the form of a panel. And for those of you in the UK, we send ours to Sheffield, and they have a specific Chorea panel, although NKX 2.1 is also included on the dystonia panel as well. And you can probably understand that by now looking at the clinical phenotypes. So again, when Manju and I wrote this review back in 2015, we brought together all the point mutations that had been reported at that point. And this isn't to look at the specific mutations, but it's just generally to look at trends and to see that the majority of the mutations sit within the exon 3 and none sit within exon 1. And I think this is probably because at least some component of the protein is essential for survival and for existence. In terms of the types of mutations, the different colored boxes represent different sorts. So underneath the gene, the green are the stop codon mutations and the purple the splice site. Above, you've got the missense mutations in orange and the frame shift in blue. So again, you can see there that not only is exon 3 the most common site for mutation, but frame shift and missense mutations are by far and away the most common mutations seen with this disorder. But as I've mentioned now several times, contiguous gene deletions also exist in this disorder, and this figure is taken from that French paper from that large case series. And as I said, they included 28 in their case series, of which 3 of whom had contiguous gene deletion. In our case series of 10, there were 2. So, not an insignificant number of individuals can have copy number variations involving this gene. I think what's interesting as well, there are no duplications that have been reported, only deletions. So very similar to, say, the SGCE gene with myoclonus dystonia. And I think what you can see from this figure here is that the deletions can vary quite enormously in size, and they obviously take out a number of surrounding genes. So often the patients who tend to have the broader phenotype or the more complex phenotype may have these deletions, and some of that phenotype may be in part because of the other genes that they take out around the NKX 2.1 gene, not purely just because of the NKX 2.1. But I hope I'm just trying to highlight that, you know, again, for that genetic testing, if you've seen a case and you're really convinced that this is a benign hereditary chorea and your point mutation testing hasn't yielded anything, then please look for copy number variants. And also, just to be a sort of a slight word of caution, and I'm sure lots of people know this, but even with next generation sequencing, you can miss you know, copy number variants, and so it's always worth doing an MLPA testing. Just, you know, as I've already mentioned as an aside, this is what we would just otherwise do as standard testing. We would always check the thyroid function test, even if there hadn't been any preceding history of thyroid disturbance, and we would probably keep a check on that with these patients. From a chest perspective, at the very minimum, we would do a chest X-ray and look for reversibility of airways obstructions, you know, the testing that is done for asthma. We've often asked the respiratory physicians to get involved, or just at least to review the patient once, and some of them have had CT scans of their thorax. And then in terms of brain imaging, we would just do a standard structural MRI brain scan, which in the UK varies between a 1.5 Tesla and a 3 Tesla. I think key to this, the vast majority of patients with this disorder have normal structural brain imaging. But if you go through the literature, there are cases, and we had one in ours, and that's the image here, where on T2 imaging, there is some high signal. This is in the thalami, but you know, other structures have shown this as well, but they are very much in the minority, and the vast majority have normal structural brain imaging. There have been a few case reports that have looked at PET and SPECT imaging and to look at occupancy of the dopamine 2 receptor, but again, these are in very small numbers and have not been done on a systematic level. But these are broadly how we would work up these patients. So, from a pragmatic perspective, what options are available for treatment? And one thing I wanted to sort of take off the list then very early on is deep brain stimulation. So I have absolutely scoured the literature, and I even did it this morning as well, because I just, I thought I might get caught out, but I cannot find a single reported case with a confirmed NKX 2.1 mutation and DBS. And I think in part, you know, the DBS literature in the context of Chorea is quite well documented now. Certainly in Huntington's disease it is, in that there hasn't been a particularly dramatic improvement, at least to the motor symptoms in the context of DBS. And that may be why some of these cases haven't gone on to receive DBS. But the literature for dystonia is good in terms of response to DBS, but there have been no cases reported to date. So what has been focused on is oral medical therapy. And moving to the last question for everybody, there's obviously no right answer here, or single right answer at least, you know, there are certainly no guidelines, and there are no randomized clinical, randomized controlled trials. So I think that's the main thing. But if you could pick just one answer, that if you were faced with a patient with this disorder, what would you pick as your first line therapy to try for management of their motor symptoms? And I'll give you a few moments to answer that.
Okay, couple of seconds to go, and I will show the results. Okay, so here are they.
Okay, so a bit more of an even spread compared to some of the previous questions, with tetrabenazine and levodopa being the most common. And as I said, I'll go on the next slide to describe, or to explain what has been reported in the literature, but that, you know, there are no clinical trial results then that we can lean on here.
Right, so I think firstly, again, the references at the bottom here are really important, but this was the table from our case series, and I think the first thing really is to note is that only 7 out of the 10 received oral medical therapy, so not having treatment is always an option that remains on the table, and obviously it depends on the severity of the motor symptoms. But in line with the answers that you gave, the most common, when Manju and I looked at across all the literature, the most commonly used are tetrabenazine and levodopa. Slightly opposing mechanisms of action for these drugs, but tetrabenazine is often used in the context of chorea, and these were the average doses or doses that were tolerated that had been with some efficacy reported in both children and adults. The levodopa that had been reported was mainly in children, and at this dose, so quite a high dose for children. And those that hadn't responded to the levodopa, it was usually because they'd used some lower doses. Again, lots of other drugs have been described, particularly trihexyphenidyl to treat the dystonic symptoms, again with varying efficacy. But I didn't feel this talk would be complete if I didn't highlight 2 other case reports that have been highlighted more recently. And this is with use of methylphenidate. So the top case report was in 2017, and then the second one in 2018. The case in 2017, there was a confirmed NKX2.1 mutation. And the child at 5 years was started on the methylphenidate to treat for their ADHD symptoms. And they noticed as a byproduct that their motor function, particularly their gait and their ambulation, improved significantly. So I think they started off on quite a low dose of sort of 5 milligrams BD, increased this to 20 milligrams, and then ultimately the child was left on a dose of 30 milligrams of the controlled release preparation. But they did describe a benefit for medication within around 30 minutes of taking it from a motor perspective, and also a wearing off towards the end of the day. Now, this second case report came a year later, and I'm not sure whether it came on the back of having seen that earlier case report, but the case here, they used the methylphenidate to specifically treat the motor symptoms in an 11-year-old child. And again, they started off with immediate release preparation at a low dose of 5 milligrams, and then gradually increased, so the case report describes between 11 and 14. And essentially what had happened is that there was generally an increase in dose of the medication on an annual basis, and the effect was really good to begin with, and then gradually lessened over the course of the year, and then they would increase the dose, and they would see improvement. So at 14, so at the end of this case report, the child was on a controlled release preparation at 72 milligrams. So, obviously methylphenidate doesn't come without its side effects and potential risks, but it was just interesting to highlight that these 2 case reports have reported good effect. So I'm just very aware of the time, and so I just wanted to press on with some final videos. So this is, effectively in many respects of overlapping disorders who look very similar, and I just wanted to show some quick videos. So ADCY5 are now a very well documented disorder, and this is a young girl that I saw as part of my PhD. So she's 3 years of age here, but again being examined, eyes closed, counting backwards, but looking, the video is not running particularly well, looking particularly at her upper limbs and her distal upper limbs. There's some fine movements there that you could quite easily see crossing over to the NKX2.1 phenotype. She also had some jerks. I think with the facial masking, it's less easy to see, but she also had some of the facial dyskinesis and myokymia that's more characteristic of the ADCY5. And then SGCE, so a disorder that I've done a lot of work with in the past. So this is a teenage boy, so he's messing around a little bit at the start here, but he also has some jerky involuntary movements involving his fingers, but then he also has a lot more of the truncal myoclonic jerks that again is very characteristic of this disorder. But then if you think back to the first NKX2.1 video as well, you can see overlap between these disorders, and it comes back to why gene panels are very useful in clinical workup. So just finally, just a couple of the autosomal recessive forms. most of these do have a sort of added clinical features which would help separate them out from the NKX 2.1. So certainly the GNA01, it originally described as having seizures and an encephalopathy, then together with some motor features, but more recently there have been pure motor descriptions, so cases with mutations in this gene without the encephalopathy component, but with evidence of dystonia and chorea, etc. The PDE10A, again, this is autosomal recessive. What's characteristic or has been described in this disorder is this diurnal fluctuation. So not always the easiest, I think, to try and get out in a clinical history, but if there's any suggestion of that on the background of this pattern of family inheritance, this might be a gene worth considering. And again, this is one of those conditions that can have abnormalities on T2 weighted brain imaging. GPR88, very rare. And I think the key with this disorder is that the chorea tends to be a bit later onset. So as if you remember the NKX 2.1, the median age at onset there was 2.5 to 3. This is 8 to 9 years old, and they tend to have more of a global developmental delay with cognitive impairment. And then finally, a much better characterized disorder, and this is a FOXG1 mutations. So again, they may have choreiform component, but also a much broader phenotype together with sort of structural brain abnormalities. I personally don't have any videos of these disorders, and I didn't want to pull other people's videos from their presentations, but I've spent a long time going through the literature to try and find what I felt were the best articles that had really good videos associated with them in case anybody wanted to go and look at examples of these disorders. And these were the references I found for each of these disorders, and these were all freely, freely available. You didn't have to have a library access to be able to access them. So I hope, if someone was specifically interested in one of these, that this might be useful. Right, I was going to stop there, but if anyone has any questions, I think they can put them in the Q&A box. So I will just open the Q&A box there.
Thank you, Kathryn. Thank you for the whole presentation and for all these suggested readings. And so, yes, we can start. There are 3 questions and 1 or 2 maybe in the chat box. So which was the clinical question for patient 1 referral?
So the first patient was referred to, this patient was seen at the Evelina Hospital in London, and they were referred in part due to involuntary movements, particularly of the limbs. And I think that the child had got to the stage in school where they were, beginning to write and to draw, and they were having difficulties with that, and that's what had been brought up. I think some people had noticed some difficulties with the running action, but I think that was less of a pressing concern at the time. So.
And then a comment, focused ultrasound neurosurgery is showing promising treatment results, better than DBS.
Yeah, so I think, there are certainly trials ongoing in this area. I think in the UK, I think our trials for this have shut. I'm not quite sure. I'm not aware specifically for this disorder, but yes, I agree, a potentially promising future area.
Is intellectual disability common in these patients?
So I think, as I said, when you've got small case series and case reports, people tend to publish on the unusual rather than the common, and so you can get this sort of very skewed perspective on what is normal for these disorders. As I said, for the NKX 2.1 cohort that we published on, intellectual disability wasn't particularly pronounced, but certainly if you look at the publication from the French team, and they did a much more systematic analysis, there's at least a proportion of patients who do have some intellectual disability. Certainly in my experience, those that do are more likely than, not exclusively, but more likely to have a contiguous gene deletion rather than a point mutation.
And do you know a support group for the families?
I'm not aware of any myself. I know certainly in the UK, some of them link in through the Dystonia Society. There may well be Facebook groups. So yeah, I'm afraid I don't know any more than that.
Okay, I will take one from the chat. So it reads, the rare NKX21 cases, I remember, for me looks more like a kind of myoclonus dystonia than chorea. For me, the term chorea in these cases is almost a little confusing. What do you think about it?
So I agree, and I think hopefully those videos of the ADCY5 and the SGCE cases at the end go to show that I think, you know, you could be presented with cases with any one of those three diagnoses and be forgiven for getting it wrong. I think it's very difficult. These fine finger movements can look choreiform, they can look jerky, they can look like a negative myoclonus, and I think there's an excellent paper from Queen Square. I don't think it was David Marsden, I think it was after that talked about essential myoclonus. And a lot of those cases have subsequently gone on to have either NKX2.1, SGCE, or ADCY5 mutations. And I think that just serves to highlight how difficult it is to try and separate those phenotypes out. I think with the NKX2.1, what's useful is that you can ask about those other things, about the respiratory and the thyroid symptoms that you don't get with those other disorders. So I think that's useful as a discriminator there.
Mm-hmm. Thank you. And another one from Juan Dario Ortigosa. Thank you very much for the detailed webinar. I have recently seen a patient with abnormalities of the left basal ganglia on brain MRI and dystonia in the right upper limb with a VUS variant in the NKX21 gene. What radiological alterations have been described in the basal ganglia in NKX2 patients? Can some cases develop dystonia without chorea?
So I think touching on the radiology to begin with, as I said, the vast majority have reported normal structural brain scans, but there are cases of structural anomalies that predominantly involve the basal ganglia. I think, you know, going through the literature, I noticed at least 6, maybe up to 10 cases reporting structural abnormalities there. So it's not unheard of. And then I myself have not seen a case with an NKX2.1 mutation with no chorea. I've seen plenty of cases with chorea and dystonia and ataxia. So I haven't seen a pure dystonia. They are reported, they're certainly reported. And I think one of the messages that I guess that I would put across is if you're seeing a case where they're predominantly presenting because of the dystonia, then I wouldn't exclude this diagnosis from your differential diagnosis. I would definitely keep it in there, because potentially it could happen.
Mm-hmm.
They should probably write that case up.
Yeah, and I get back to the Q&As. So Giacomo is asking, thanks for the great lecture. How do you explain the possible responsiveness of the motor phenotype to both dopaminergic and monoamine depleters drugs?
Yeah, so I think that's true, and and that's very, very difficult to explain from a pathophysiological mechanism. So tetrabenazine tends to be a depleting drug. Levodopa, obviously, you're giving back monoamines, and methylphenidate increases the level of dopamine and noradrenaline in the synaptic cleft. So I think that is very tricky. I think the tetrabenazine has clearly been used in this setting because it has been shown to be effective in other forms of chorea. So I think what we need is better understanding of the pathophysiology of this disorder to understand whether it's a hypo or hyper monoaminergic disorder that I think would better guide that. But I think, unfortunately, at the moment, therapy is slightly trial and error, and there may be, because we see so much phenotypic variation, there may be some variations in terms of the underlying pathophysiology. Although, a single gene disorder, you'd expect it to be, a common pathway, or at least a common mechanism. So I agree, it's very hard to explain that away.
And there are two similar questions. So one is penetrance complete? Are there relatives with later onset? And is there any medical treatment that is known to worsen benign choreas? Secondly, do you know any cases of late onset benign chorea, for example, at the age of 40?
So I don't know any with confirmed NKX 2.1 mutation. So certainly we have presentations later in life who've presented with chorea, and we've worked them up for all the degenerative causes, and they haven't, those have all been found to be negative. So it's effectively a benign chorea, but not with mutations in the NKX 2.1. So I don't know of any adult onset cases there. I think, this story of the chorea stabilizing or becoming more quiescent in adult life is pretty consistent for those with mutations in this disorder. And I can see a question in terms of therapy in adult life. I have to say the few adults that I see in clinic, for the most part, if they're not having any difficulty with functioning, we don't tend to treat them unless there's some marked impairment. I'm not sure I can remember all the other questions you gave me, sorry.
Yes, I think maybe a medical treatment worsening benign choreas.
Well, I think that there are lots of drugs that are known to cause potentially hyperkinetic movement disorders. Certainly the neuroleptic drugs and some of the tricyclic antidepressants. Specifically in this context in therapy, we certainly didn't find any evidence of, and I haven't seen any reported literature of worsening per se with when you're trying to make the motor symptoms better. I think there was one case report around levodopa, however, this is from the back of my mind, where they stopped therapy and restarted, and that caused some worsening of symptoms, but not specifically.
Yes, there is another question. I'm not sure if I understand it well, but maybe you, Kathryn, from the chat. So children with presentation with essential tremor, especially the younger ones, should we consider these disorders as distal movement disorders? Might be misdiagnosed as tremor. Hence, is this distal chorea or is it distal myoclonus?
So I think patients who present in childhood with tremor. I mean, I think the tremor looks different from the videos I've shown. So I think I'm certainly not advocating that every child with tremor would be tested for an NKX 2.1 mutation. I think the question over chorea versus myoclonus alludes back to some of the previous questions. I think it's very difficult to separate the two out. I think, on the whole, the consensus in this particular field has been that the movements are choreiform, but there is superimposed myoclonus as well. But, as I said, I think, anyone would be forgiven for, calling in this setting, the myoclonic jerks rather than chorea. And again, trying to separate those diagnoses with particularly the ADCY5 and the SGCE is very difficult, particularly I think in younger children.
Yes, one other question. Since symptoms tend to improve with age in adulthood, these patients should continue therapy?
So, I mean, I think you have to see how the patient's doing. As I said, for us, for adults who don't have any functional impairment, unless they're very keen on taking some medication, we don't tend to use it. We might discuss it, but we don't tend to use it. For those who do have functional impairment and it's impacting either their job or their home life or whatever, we would try, we would start some therapy and try to gain some effect there. But if they're relatively stable and then their function isn't impaired, I don't see any need for medication.
And another one from Belen Perez. I have also had the experience of a good response with methylphenidate in a child and his mom with benign chorea, not only regarding movement, but also regarding ADHD symptomatology. Do you think there is a specific mechanism for NKX2-1 on the dopaminergic pathway?
So I think, that's a really good question. And I think, in terms of this overlap of the psychiatric and the motor symptoms, that first case report that reported this, it was targeted for the ADHD symptoms. I think certainly if you look at, the sort of very boring side, but the embryonic development of neurons and where different neuronal subtypes develop from, NKX 2.1 positive neurons and neurons which classically, or dopaminergic neurons which classically form the sort of midbrain dopaminergic neurons, those come from the same embryonic origins. NKX 2.1 expression is very important in separating out those neuronal populations. So it's not unreasonable to think that some of the origins of the pathophysiological mechanisms lie there, and that by altering dopaminergic neurotransmission that you can lead to some improvement in symptoms. But there's certainly no human tissue-based evidence to support that. And actually there hasn't been an awful lot of work in animal models looking specifically at monoamine neurotransmission in this disorder.
Mm-hmm. Thank you. Are there cases with mutations without penetrance?
I'm not aware of any. It's autosomal dominant without any variation in penetrance. So not like, for example, the SGC with the maternal imprinting, or like DYT1, with that varied penetrance. These are completely penetrant, as far as I'm aware.
Mm-hmm. And the last question, are estrogens contraindicated in adult women?
I'm not sure about that question. With adult women with this disorder, I'm not aware of any contraindications. I think certainly all the adult cases, we've always got the endocrinologists involved, even if their thyroid function has been stable, just I think for a bit of support. So, I think this is something that an endocrinologist probably could answer far more accurately than me, but as far as I'm aware, there's no contraindication to estrogen therapy.
Mm-hmm. Okay, so we don't have any more questions. Thank you, Kathryn. Thank you for responding all those questions so clearly and comprehensively. And thank you for showing this or for presenting this talk. And to all of the others, thank you for joining. And the next webinar takes place on the 8th of June, and it's on imaging MRI pattern recognition in leukodystrophies. So stay tuned and have a nice evening. Thank you. Bye-bye.
Bye. Bye-bye.
Bye.